Yes, sir.
Right. Okay. So, hope you had a good week. Let us get back to our studies. Today, we will start with thorax. We will finish it today. It's not a very big topic. A few important topics are there. So, pay attention and take down notes. And at the end, like every class, we will discuss some questions. So, to start with, the mediastinum, as you all might remember these things from your UG days. So, it is a central compartment of the thoracic cavity between the two pleural sacs. Okay, and it can be divided into two parts. So you see, this is the manubrium. This is the manubrium. This is the sternum. This is the xiphoid, and these are the vertebra. So a line joining this manubriosternal joint to the lower border of T4. This is the sternal angle. This divides the entire mediastinum into two broad components. This one is the superior mediastinum above, and this large space below is the inferior mediastinum, which is again subdivided into three parts: the anterior, middle, and posterior. We will take up each of these spaces and discuss briefly in details. Okay. So mediastinum, the space in the thorax between the two pleural cavities, bounded anteriorly by the sternum, posteriorly by the vertebra T1 to T12, above by the thoracic inlet, below by the diaphragm, divided by the sternal plane into superior and inferior mediastinum. Inferior has three parts: anterior, middle, and posterior. Okay. So from this diagram only, if you see, this is the superior mediastinum, this part. So what does it contain? So as I said, it is continuous with the thoracic inlet above superiorly, below with the inferior mediastinum, anteriorly by the manubrium, posteriorly by the vertebra T1, 2, 3, 4, and laterally on two sides by the pleura. What does it contain? It contains, as you can see in this diagram, the second one, it has the arch of aorta with its branches, the brachiocephalic, the common with the right subclavian, right common carotid, then the left common carotid, left subclavian. Then you have the SVC with its tributaries, the brachiocephalic veins. Then you have three pairs of nerves: the vagus, the phrenic, and the sympathetic trunk. And then you have thymus and uh, three tubes: the trachea, esophagus, and the thoracic duct going from the posterior aspect. Okay, so two main vessels, three pairs of nerves, two important tubes: trachea, esophagus, and the thoracic duct. Thymus is present in both the superior and mid antemediastinum. It kind of extends like this. So it's actually a component of both the mediastinum, superior as well as anterior. Okay, so far? Yes? Yes or no, guys?
Yes.
Please respond. I'm not talking to myself.
Yes, sir.
All right. So this is a schematic diagram of what we discussed. This is the neck, the thoracic inlet, the transverse plane between the manubriosternal joint, and this is the T4 over here. So this is the superior mediastinum. This is the inferior with three parts: anterior, middle, and posterior. Okay. Now, coming to the inferior mediastinum, which is three parts. The first part is the anterior mediastinum. So obviously you can visualize the boundaries: laterally by the pleura on each side, anteriorly by the back of the body of sternum, posteriorly by the anterior aspect of the pericardium. Roof, it is continuous with the superior mediastinum. and flowed by the diaphragm here. What does it contain? It contains the thymus, as I had said, and some fat and lymphatics. So it is mainly a kind of cushion to protect the more valuable and important and more delicate structures underneath. Then comes the middle mediastinum. This is the second part of the inferior mediastinum. It contains again, think and you can understand, anteriorly the anterior margin of the pericardium, posteriorly the posterior pericardium, laterally the mediastinal fluid of the lungs, superiorly continuous with the superior mediastinum, inferiorly the diaphragm. Very simple. What does it contain? Again, very simple. It contains the heart with its vessels. So heart with the pericardium, vessels, the aorta and the pulmonary trunk, SBC, the phrenic nerve, and the tracheal bifurcation. Okay. So there is the heart with the ascending aorta, the SBC with its tributaries, the pulmonary trunk, the phrenic nerves, the cardiac nerves, and the tracheal bifurcation. So you see, a simple way to remember a few things is that in the inferior mediastinum, you have the anterior, the middle, and the posterior compartments. Anterior, just some fat, lymphatics, and thymus. The structures in the middle mediastinum, they remain in the thorax. They do not go beyond the thorax. Okay. So the tracheal bifurcation, the heart with its red vessels, the SBC, pulmonary trunk, the phrenic nerves, they all tend to remain in the thorax. If you continue to the posterior mediastinum, something is different over here. All the structures of the posterior mediastinum, they do not stay in the thorax. They either come into thorax from the abdomen or they go from thorax into abdomen. Like the thoracic aorta, it will descend into the abdomen. Aorta, the esophagus, thoracic duct, they all go. So these two go into thorax. Thoracic duct, azygous vein, they come in the thorax from the abdomen and sympathetic trunk. So structures in the posterior mediastinum, they do not remain in the thorax. They either come or they go from the thorax. So if you're in doubt, you can just think of where does the structure come from or where does it go to. Boundaries, again, very simple. Laterally, the pleura on each side, anteriorly, the pericardium, posteriorly, it is the end, it is the very back side. So you will have the vertebra, T5 to T12. Roof goes to the superior mediastinum, floor the diaphragm. Okay. So are the three parts of the inferior mediastinum clear to all of you?
Yes, sir.
Okay. I would like others to respond also. Now, this diagram will summarize what we have learned so far. Mediastinum, it is located between the right and left pleural cavities. In the superior mediastinum, the structures pass from the head and neck to the thorax. That is the pathway. Anterior, it has some fat tissue to protect the deeper structures. Middle has the heart and the great vessels. And posterior, the structures that pass through the thorax are in the very back of the mediastinum. And components, again, superior, the thymus, the aortic arch, SBC, thoracic duct, vagus nerve, recurrent nerve. Anteriorly, you have the thymus and the some nodes. Middle, you have the heart and all the important vessels, the great vessel roots, ascending aorta, pulmonary trunk, SBC, pulmonary veins, and phrenic nerves, all these things. Posteriorly, you have the esophagus, thoracic aorta, azygous vein, thoracic duct, sympathetic chains. All right. This is a summary of what we have learned so far. Next, the breast. So breast is basically a modified sebaceous gland. Remember that. This is a structure present in the skin itself. It doesn't extend inside the thorax. So if you can see this cross section, this is the chest wall with the ribs and the pectoral fascia. This is the pectoralis major muscle. And so it is, the breast is lying above the muscles outside the chest. Okay, it is a modified gland from the skin itself. What are the boundaries? Boundaries are, this is the parasternal border. The sternum will be here. So lateral border of sternum to the mid-axillary line, and superiorly from the second rib to the sixth rib. Okay. This is the breast extent, and it is divided into 4 quadrants for clinical purposes: upper inner, upper outer, and lower inner. And there is an extension of the breast tissue towards the axilla known as the axillary tail of Spence. Of these things, you must remember upper outer quadrant. This is the most common site for all breast pathologies, be it a breast cancer, be it a fibroadenoma. Most importantly, it is important for cancer. So the most common location for breast cancers is upper outer quadrant. Why so? Because this is the largest quadrant. This is the area with the maximum breast tissue. So by simple rules of probability, the incidence of breast cancers is maximum in the upper outer quadrant. Is that clear?
Yes, sir.
Right. Then the blood supply of the breast. Two important branches: the lateral thoracic artery, which is a branch of the axillary artery, and the internal thoracic artery, branch of the subclavian. And there are the anterior and the posterior intercostals. The blood drains into mostly axillary vein and internal thoracic veins. Then the lymph nodes of the breast, very, very important, again for a clinical, practical aspect. Look at this muscle. This is the pectoralis major muscle, okay? And there are 3 groups of lymph nodes: 1, 2, and 3. 3 levels rather, level 1, level 2, level 3, which are described in relation to the pectoralis minor muscle, okay? So level 1, they are present, this group, okay? Inferolateral. So this is the lateral side. This is the sternum here, ribs, as you can see. So below and outwards, this is the P minor muscle. Inferolateral to pectoralis minor, you have the lateral group, subscapular group, and the pectoral group. Okay. These 3 groups. Then level 2 is this group. It is behind, posterior to the pectoralis minor muscle, which is the central group. And the level 3 or the apical group, it is superomedial to the pectoralis minor apical group, also known as the infraclavicular group. Okay, so there are 3 levels of lymph node, levels being described in relation to the pectoralis minor muscle. This is a very important aspect in relation to management of breast cancer. Okay, the involvement of lymph nodes changes the staging and therefore the management of breast cancer. Then we move on to the ribs. So all of you have seen ribs. For a typical ribs, there are a few bony landmarks which make them a typical rib. What are the landmarks? They have 2 articular facets for making the joint with the vertebra. Then you have a tubercle, again for a joint with the vertebra. And at the inferior border, you have the costal groove for the intercostal veins, artery, and the nerves. So these features identify a typical rib. So what are the differences in the atypical rib and what are the atypical ribs? So ribs 1, 2, 10, 11, and 12, they are atypical ribs. Why so? So the first rib, it is shorter and wider than other ribs. Instead of 2 facets, there's only 1 facet. And the superior surface is marked by 2 grooves to make way for the subclavian vessels. So what kind of a question you can get from here? They may describe a rib to you: the shortest rib, the widest rib, rib with 1 facet, rib with 2 grooves on the surface. So all of these will mean the first rib. They may ask you, the first rib has 2 grooves. What are they for? The answer is subclavian vessels. Then the second rib has a specific roughened area on its upper surface for the origin of the serratus anterior muscle. Then the 10th rib, again only one facet. Okay. And 11th and 12th ribs, there is no neck, again one facet. Okay. So first rib is very different. You must remember the few specific features of the first rib. All right. Now, posteriorly, this is the vertebra. The ribs form two joints at the vertebra. Okay. Costotransverse and costovertebral joint. This is why there are these two groups of facets. The tubercle forms one facet for the costotransverse joint, and this is the costovertebral joint. And then, so posteriorly they form two joints. Anteriorly the attachments vary. All right. So the first 7 ribs, as you can see here, 1, 2, 3, 4, 5, 6, 7. So the first 7 pairs of ribs, they attach independently to the sternum. They all have their separate attachments to the sternum. Right? Then the 8th, 9th, and 10th ribs, the blue colored ones, this, and this. So they join the rib above. This joins this one, this joins this one, this joins this one, and they all have one common joining to the 7th rib. Okay. So the first 7 ribs, they attach independently to the sternum. 8th, 9th, 10th ribs, they join to the costal cartilage above them. They are called the false ribs. And the ribs 11 and 12, if you can see in this diagram, the red ones, they do not have any anterior attachment. So they end in the abdominal musculature. They are called floating ribs. Okay. These names you must remember. They will just ask you which of the following are floating ribs, and they'll give you phone numbers 1, 2, 3, 11. Same for false ribs. They will give you phone numbers and ask you which of the following is a false rib. All right. Are these ribs, the naming, these clear to you?
Yes, sir.
Okay. Now, this diagram, we had kind of discussed this when we had read about upper limb. So this is the manubrium, the sternum. This is the first rib. This is the clavicle. This is the scalenus anterior muscle. This one, this muscle. This one behind is the middle scalene muscle. So anterior to the anterior scalene is the subclavian vein and the phrenic nerve. Okay. Between the anterior and the middle scalene muscles is subclavian artery with the brachial plexus. Okay. This we are discussing upper limb. Anterior to anterior scalene, subclavian vein, and the phrenic nerve. Between the anterior and the middle scalene lies the brachial plexus and the subclavian artery. Then one occasional finding known as the cervical rib. So, as you see, the ribs they start from the T1 vertebra. Sometimes there may be a bony projection from the C7 vertebra from the transverse process. Okay. So, this may become a complete rib like this, or it may be a part rib like this, and the remaining may be a fibrous band to the first rib. So either a complete rib or a partial rib followed by fibrous band. Whatever it is, vertebra starting from the rib from the C7 vertebra is known as the cervical rib. Why is it important? Because it may compress the subclavian artery, leading to some neurovascular symptoms of the upper limb. Okay. Next, look at this diagram. Here you have the skin on this side. So you have the skin and the subcutaneous tissue. Then there are three layers of the intercostal muscles. Okay, the external, the internal, and the innermost. Between the internal and the innermost intercostal muscles lie the neurovascular bundle, comprising of the intercostal vein, intercostal artery, intercostal nerve, and lymphatic. Okay. So if you remember this diagram, we had read the costal groove runs in the inferior border of the rib, right? So here, this is the costal groove at the inferior aspect of the nerve of the rib, and this is where the neurovascular bundle runs. Why is this knowledge important? Because sometimes you may have to penetrate this layer. Suppose there is a hemothorax or a pneumothorax or a pleural effusion. You need to enter the pleural space to put a drain, okay, to put a chest tube to drain the air, the blood, the fluid, whatever it is. So at that point, you must remember, you must remain close to the upper border of the lower rib of the space you are entering. You have to enter through an intercostal space, okay? So when you enter the space, you must try to touch the lower rib and stay close to the upper border of the lower rib instead of going above and getting close to the lower border of the upper rib. Is that clear? You have to stay close to the upper border of the lower rib so as to avoid injury to the neurovascular bundle, which is present at the lower border of the upper rib. Is that clear?
Yes, sir.
Okay. So keeping this principle in mind, let us see about the intercostal drainage. So there may be something known as pyothorax, pus in the thoracic cavity, hemothorax, blood, pleural effusion. There may be pneumothorax. So in these conditions, you might need to put in a chest drain to drain whatever is contained in the pleural space. So for that, we have a few safety landmarks so as to avoid injuring the uh, other structures and to efficiently, accurately enter the pleural space. So this is the triangle known as a triangle of safety. Okay. The triangle of safety is formed by anteriorly you have the lateral border of this major muscle. Posteriorly, it is the lateral border of the latissimus dorsi muscle. And the floor is formed by the sixth rib. Okay. So you enter the fifth intercostal space in the anterior or the mid axillary line. Okay. So you identify a triangle between the anterior axillary fold, the posterior axillary fold, and the sixth rib. Okay. Which is the lateral border of pectoralis major, which forms the anterior axillary fold, the lateral border of the latissimus dorsi, which forms the posterior axillary fold, and the sixth rib. You stay above the sixth rib to enter the fifth space. This is known as the triangle of safety. This is most commonly used for putting a chest tube for pneumothorax, but this is the general landmark which we follow when we are putting in a chest tube. And as I had said, you must remain close to the lower rib to avoid injury to the neurovascular bundle, which is near the above upper rib. Okay. Are these landmarks, these boundaries clear to all of you?
Yes, sir.
Okay. So moving on to the heart. This is the heart. All of you will know the important areas. So this is the right atrium. This is the right ventricle. This is the left ventricle. This is the left atrium. The ascending aorta with the three branches. This is the brachiocephalic trunk, which gives the two branches. Then the left common carotid artery, the left subclavian artery. So branches of arch of aorta is often asked from right to left. We have the brachiocephalic trunk giving the subclavian, right common carotid, Then individually, you have the left common carotid and the left subclavian. Then you have the pulmonary trunk giving the pulmonary arteries, right and left, and SVC, IVC, abdominal aorta. Inside of the heart, again, a few important points you must know. So, this is the right atrium, this space. It is divided by this ridge, elevated thickened tissue known as the crista terminalis, okay, which divides into a smooth sinus venerum and a rough atrium proper. Sinus venerum is where the blood comes in from the SVC. Then you have this fossa ovalis, which is a remnant of the foramen ovale in the embryonic stage. Foramen ovale is a foramen, it is a hole between the right and the left atrium. After birth, this foramen closes off to keep the proper interatrial septum. Then you have the valves. On the right side, you have the tricuspid valves with three cusps, 1, 2, and 3. And on the left side, you have two cusps, bicuspid mitral valve between the left atrium, left ventricle. Then in the ventricle, as you can see, a markedly thickened wall. This is the left ventricular wall. This is the interventricular septum. This is the right ventricular wall. Very thick wall, muscular walls. And the valves. So the bicuspid, tricuspid valves, they are held, the cusps, the valves are held by some cord-like fibrous bands known as the chordae tendineae. These chordae tendineae, they are attached to few groups of muscles known as papillary muscles, these muscles, which are elevations of ridge-like projections of the interventricular wall in which is known as the trabeculae carni. So you see this irregular wall inside the ventricle. These are known as trabeculae carni. So from these trabeculae carni, there are some prominent muscular projections known as papillary muscles. These papillary muscles hold these valve cusps to prevent them going back into the atrium. Okay, is this clear? So why you need to know these? They will just give you a few names. They may ask you trabeculae carni is present in atrium, ventricle, interventricular septum, like this. So just remember the important names and where they are found. Then the heart's conducting system. You start with the SA node, then there's the AV node, then there's the atrioventricular bundle, a bundle of His, and the Purkinje fibers. How does this impulse pass? So during one full contraction, there's an action potential generated in the SA node. Okay. So SA node is present in the right atrium, somewhere over here. Okay. SA node. So SA node is the pacemaker of the heart. It generates the action potential. It is the pacemaker of the heart. So this impulse then travels along the atria, causing the atria to contract, and then they reach the AV node, the atrioventricular node, between the atria and the ventricle, where there is a pause. Okay, so the signal is delayed. This is known as the pace setter of the heart. Okay, from AV node, the impulse then goes into the bundle of His, which is present in the interventricular septum, like this, and then they split into Purkinje fibers, goes to the two sides along the walls of the ventricle, causing the ventricles to contract. Okay, so the impulse starts from the SA node, goes along the atrium, atria contracts, pauses at the AV node, then goes along the interventricular septum, along the bundle of His, and then divides into the two bundle branches, right bundle branch, left bundle branch, along the two ventricular walls, causing them to contract. Then the heart's surfaces and the borders. So heart is described as a pyramid just fallen over. So if you see this pyramid carefully, take a moment, see this properly. So this slope is towards you, this yellow colored slope. This is the anterior surface, it is towards you. Okay. The straight wall is at the back side, the base of the heart. And the flat inferior aspect is the diaphragmatic surface of the heart. So the three surfaces, one sloping surface towards you, the anterior surface, one straight base, which is the back side, and one horizontal diaphragmatic surface, which is the inferior surface of the heart. And then on two sides, there are the two other surfaces. So anterior surface formed by the right ventricle, the base, the back side by the left atrium, the diaphragmatic surface by the left and right ventricles, and the two sides, left pulmonary surface, left ventricle, right pulmonary surface, right atrium. Is this clear? So these are the surfaces. And the borders, the superior border formed by the left atrium, right atrium, and the great vessels. The right border, right atrium, left border, the inferior border by the left ventricle, right ventricle, and left border by the left ventricle. Apex of the heart is formed by the left ventricle. Okay, this is the apex of the heart. This is the apex of the heart. The apex particularly is formed by the left ventricle. Okay, so surface and borders of the heart. Is this clear?
Yes, sir.
Okay, so I hope you are speaking for everyone. Now the blood circulation of the heart. So obviously it starts from the aorta. Two main branches, the right coronary and the left coronary. Right coronary gives off the posterior interventricular artery and the right marginal artery. Left coronary gives off the left anterior descending artery, then continues and gives off the left circumflex, left marginal artery. Okay, this is the schematic diagram for you to remember. Aorta gives off the right and left coronaries. Right coronary gives off the right posterior interventricular and the right marginal. Left coronary gives off the left anterior descending, left marginal, left circumflex. So how do they appear? Where do they run? On the heart. Let us see that in this diagram. So the anterior aspect, as you can see, the right coronary here, this is the right coronary. On the back side, it kind of, as you can see, it goes here, it comes here, and it goes posteriorly, which you can see here. This is the right coronary continuing over here, this one. And then it gives off the right marginal artery and the right posterior interventricular artery. Okay, this one. So right coronary giving off the posterior interventricular artery, this one on the back side as you can see, and the right marginal artery, this one at the margin. Okay, that's from the right coronary. From the left coronary, what do you see here? It starts, it gives off the left anterior interventricular or left anterior descending. This one. This one runs in the along the anterior aspect, the left anterior interventricular, left anterior descending artery. Then this continues to form the circumflex artery. It goes here and goes to the back, which you can see here, coming like this. Then it gives off the left marginal artery. Okay, so these are the arterial supply. Veins start from the coronary sinus. You have the great cardiac vein on the back side coming to the front. Then you have the posterior cardiac vein, middle cardiac vein, both seen on the back, and in the front you can see the anterior and the small cardiac veins. Okay. So are the arterial branches clear to all of you? This is important. Everyone? Yes, okay. So this thing doesn't work sometimes. All right. So you see from here, the aorta gives off the right coronary artery and the left coronary artery. Right coronary gives off one branch, the posterior interventricular artery, and the right marginal artery. This is a schematic diagram of what we see here in this actual diagram. So follow this diagram. You start with the right coronary over here. This is the aorta. Right coronary starts here. This is the anterior view, and this is the back side, the posterior view. So right coronary starts over here. It comes like this. It gives off the marginal artery, this one, along the right margin. Okay. Then this continues to the back side. It goes to the back over here. The back side, you can see here, it is continuing as the right coronary artery. It is coming like this, and giving off this branch over here, which is the posterior interventricular artery. So two arteries, we have seen how they appear on the heart. Come to the left side now, the left coronary artery. It starts from here. Left coronary artery starts from here. First branch it gives is the left anterior descending artery, which is this one. Anti-interventricular, also known as the anterior descending artery. So first branch is this left anterior descending artery, this one, coming straight down. This one then continues as the circumflex artery here. Again goes to the back over here. You can see it back, coming in the back side, circumflex artery, and this continues as the left marginal artery, this one. Okay, so left coronary, left anterior descending, we have seen here. Left circumflex, we have seen here. Left marginal, we have seen here. These are the arteries, and the veins, the coronary sinus, where all the veins finally merge to drain into the SVC. And other tributaries are the great cardiac vein, the middle cardiac vein, posterior cardiac vein, anterior cardiac vein, and the small cardiac vein. So all the veins merge into the coronary sinus. Okay. Is this clear now? Okay. Now, something known as the dominance of the heart. So as we saw here, this posterior interventricular artery, this is a branch of the right coronary artery. Okay, usually. So if the posterior interventricular is a branch of right coronary artery, it is known as the right dominant heart. If it is from the left coronary, it is the left dominant heart. So dominance is determined by the posterior interventricular artery. Okay. Why is this? What does it mean? I don't know. This has been asked, so I have put it here. Now, what do these arteries mainly supply? The right coronary artery supplies the right atrium, SA, and the AV nodes. Posterior interventricular, which is a branch of the right coronary, supplies the posterior third of the IVS, the interventricular septum, and the left anterior descending, which is a branch of the left coronary, supplies the anterior part of the IVS and the apex of the heart. Okay. So left anterior descending, LADA. This is the most important, the largest branch of all these coronary arteries. Okay. So SA node, AV node supplied by the right coronary, remember this. Apex supplied by the left anterior descending. Okay. So anterior descending can also be known as the anterior interventricular artery. Now look at this. Here, this diagram we have just seen. What I want to show you here is there are a few grooves on the heart surface through which these vessels run. As you can see, they are not randomly scattered all over the heart. They have a distinct pattern in where they are lying. Okay. So this groove. So you have the right atrium over here, the left atrium over here, the right ventricle over here, left ventricle over here. So this groove, the yellow line, this is the atrioventricular groove between the atria and the ventricle. They divide the heart into upper and lower segments. Atrioventricular groove, also known as the coronary sulcus. So what lies in this sulcus, in this groove? Here lies the right coronary, left coronary, and the left circumflex artery. Okay. In the same way, you can see this branch, this group of vessels, they line the anterior interventricular sulcus. This sulcus lies between the right and the left ventricles. So anterior interventricular sulcus, which contains the anterior interventricular artery and the great cardiac vein. In the same way, on the back side, there is another groove known as the posterior interventricular sulcus, where you have the posterior interventricular artery and the middle cardiac vein. So anterior interventricular artery is a branch of the left coronary artery. Posterior interventricular artery is a branch of the right coronary artery. Okay. Clear so far, all of you? Yes or no?
Yes, sir.
Yes.
Just a minute. Yeah, okay. So continuing. This is a brief few points about the development of the heart. So the heart starts as a tube. Then it folds upon itself to form what resembles the adult heart by 35 days. Okay. By 35th day of intrauterine life, the heart more or less takes its final shape. So in this tube, there are various parts which ultimately lead to the various parts in the adult heart. What are the parts? The truncus arteriosus, then you have the bulbus cordis, then you have the primitive ventricle, the primitive atrium, and the sinus venosus. So when it folds upon itself and forms this kind of a structure, so as you can see, the truncus arteriosus, this part will ultimately form the aorta and the pulmonary trunk, this area. Okay. Then the bulbus cordis, this will form the smooth part of the right and left ventricles. As you remember, I had shown you in the inside of the atrium, there was the crista terminalis, the smooth and the rough part. The smooth part came from the bulbus cordis region. Then the primitive ventricle, which formed the trabeculated part. The primitive atrium formed the trabeculated part of the atrium, and the sinus venosus, they form the smooth part of the right atrium, the SA node, and the coronary sinus. Okay, the tube comes like this, then it folds upon itself like this to form these structures. They may ask you, they may give you one of these names and ask what do they form, or the opposite, they may ask you what does this area come from. So is heart clear to all of you? Yes? Okay.
Yes, sir.
Now the lungs. So lungs, we have two lungs, right lung and left lung. Right lung is divided into three lobes by two fissures. Left lung, two lobes by one fissure. Okay. Now the tracheobronchial tree. So it comes from the trachea. The trachea divides into the right and left bronchus. Now, the actual uh, orientation is not like this, not so symmetrical. It is more of something like this. The trachea coming like this. It is like this. Okay. This is the right side. This is the left side. Okay. So this is a very common, very important MCQ question. If there is a foreign body in the airway, it most commonly lodges in the right bronchus. Why so? Because it has a more vertical course and is a wider in caliber. Okay. The left bronchus has a more acute turn and narrow in caliber. Okay. So right bronchus, most common site of foreign body lodgement because of its wider caliber and a more straight course in line with the trachea. Then the main bronchi, this right and left bronchi, they divide into lobar bronchi. So you have three lobes, superior, middle, inferior. So you have lobar bronchi for each lobe. Then inside the lobes, you have bronchopulmonary segments. You have segmental bronchi for each bronchopulmonary segment. And inside, they further subdivide. And at the end, they are the terminal bronchioles, which form the respiratory bronchioles, which ultimately end up in balloons called alveoli, the air-filled sacs at the very end of this airway, where the gaseous exchange occurs between the blood and the airways. Okay. And these bronchopulmonary segments, so there are 9 on each side. Each bronchopulmonary segment will have its own uh, segmental bronchi, its own blood vessels. Okay. Blood supply of lung as a whole, the bronchial arteries, they come from the aorta, supply the bronchi, lung roots, visceral pleura, and lung tissue. Bronchial veins, the right bronchial vein goes into the azygos vein, left into the accessory hemiazygos vein. All right. Now, this is the hilum of the lung. Okay, this is the right lung, this is the left lung. This is anterior, this is posterior, as you can see the vertebra over here. So, what is being shown here mainly? The lung hilum has so many important structures. These are the pulmonary arteries. These are the bronchi. These are the pulmonary veins. This nerve, phrenic nerve, crosses anterior to the hilum, and the vagus nerve crosses posterior to the hilum. Similarly, over here on the left side, this is anterior, this is posterior, this is the hilum with the pulmonary artery, the bronchi, and the veins. The phrenic nerve, this one. Phrenic nerve is anterior to hilum, vagus nerve is posterior to hilum. So, this rule you must remember. At the lung hilum, there are two nerves. Phrenic nerve crosses anterior to hilum, vagus nerve crosses posterior to hilum. All right. Is this clear to all of you? Any questions so far?
Sir, please repeat.
All right. The lung hilum is clear to all of you. There are important structures over here. The only point I'm trying to make here is these two nerves are there in relation to the hilum, the phrenic nerve and the vagus nerve. On both right and left side, the phrenic nerves, they cross anterior to hilum, vagus nerve crosses behind the hilum. That's all. Okay.
Okay, sir. Thank you.
And a few relations of the trachea and the bronchi. So the trachea starts from the C6 at the level of cricoid, divides at level of T4, the right bronchus and left bronchus. Right, as I said, it is wider, shorter, steeper. That's why it is the most common site of foreign body lodgement, the right side. And that's all from this slide mainly. You must remember starting is C6, ending is T4, and how the right bronchus is different from the left bronchus. This you must remember, it's an important landmark, the sternal angle. Okay. This at the manubrious sternal joint, sternal angle of Louis. Sternal angle of Louis. There are various important events which occur. So, first of all, when you are counting ribs, say you want to put in a chest tube, you count ribs. How do you start? You first palpate the manubriosternal joint. The rib adjacent to that joint is the second rib, and then you start counting. Okay, the corresponding space is below the numbered rib. First space is below first rib. Second space below second rib. Okay, so to identify ribs, it's very important. You must identify the sternal angle, find the second rib, count the ribs and the corresponding spaces for whatever purpose you want. Then, aorta. The ascending aorta ends, the arch of aorta begins and ends, and the descending aorta starts. So this is the plane like this. The ascending aorta comes like this. So it's a very simple thing put into a lot of words. Ascending aorta ends over here. The arch of aorta begins over here. Arch of aorta ends over here. Descending aorta begins over here. All at the same level, obviously. So it is. So just this is to put it out there. They may ask you any of these points. Ascending aorta ends at what level? Arch of aorta begins at what level? So answer to all of this is at the sternal angle. Now this corresponds to the T4 level. Okay. Sternal angle, if you draw a straight line, T4 level. So they may ask you in both ways. At T4 level or sternal angle, what are the important events? Rib I told you, aorta I told you, then the trachea. Trachea bifurcates, pulmonary trunk bifurcates. The left recurrent laryngeal nerve hooks back at this level. The azygous vein drains into the SVC. Thoracic duct crosses from the right side to left side. Okay, so all these important events, they occur at this T4 level or at the sternal angle of Louis. Is this clear? Just like we had read a few important events, important structures at the transpyloric plane. Similarly, at this level, these are the important things present in the thorax. Clear?
Yes.
So any questions so far from all the things we have discussed?
सर extent of lung and extent of pleura एक बार बता दीजिए.
Yes, we'll come to that. There's a question on that. Okay. Apart from that, anything else? Okay, so let's start. Tell me now. I want all of you to participate, not these two voices only. I want all of you. A patient was found to have an extra rib on a cervical spine X-ray. Which artery is most likely to be compressed? Answer in the text box. Yeah. So very simple. This is the cervical rib. The artery it is compressing is the subclavian artery. Next, the right coronary artery supplies all except apex, IVS, IAS, and the AC node. Where are the others? Please try. We have just discussed this few minutes back. Okay. So you remember this table which we had seen? So apex is from the left anterior descending. Okay. Answer is A. Next, thoracic duct drains all the following areas except we had kind of discussed this in the abdomen when we had discussed the thoracic duct formation in the course. Yeah. So the answer is right upper limb. It has drainage from all the other parts of the body. So it forms from these two lymphatic trunks. These lymphatic trunks they drain from the lower limbs and the abdomen. They form the thoracic duct, which goes up like this and crosses and joins over here. So before it joins here, drainage from this side also comes and joins here. The right side of the head and neck and the upper limb does not drain in thoracic duct. Okay. So right upper limb is not drained by thoracic duct. Now, someone had asked this. So let us see what you recall. Tell me. At the mid axillary line, The parietal pleura extends up to the level of which rib? All right. So it's a very simple thing to remember. First of all, always remember in this topic, the extent of pleura with the ribs, there are no odd numbers, only even numbers. Okay. First rule, must remember. Second, you remember this. Where am I? Yeah. So remember this table. Just remember one part, the other part automatically complete. So what we have here is you first see this diagram to have an idea. The ribs are numbered 1, 2, 3, 4, 5, 6. The inner gray area till here is the lung. Okay, lung is still here. Now there are two layers of the pleura, the visceral and the parietal pleura. So the visceral pleura is equivalent to the extent of the lungs. It tightly covers the lung, and the parietal pleura is attached to the inside of the chest wall. Okay, so there is a potential space between the lung with the visceral pleura and the parietal pleura. So when things start to accumulate in this pleural space, which is the space between the visceral and the parietal pleura, it may be air, blood, fluid, pus, whatever it is. So lung is a very elastic, compressible organ. So lung starts getting compressed and things start accumulating in the pleural space. The extent of the pleura. So visceral pleura or the lung in the anterior axillary line and in the mid clavicular. So we remember in the front mid clavicular line, in the center mid axillary line, and posteriorly the mid scapular line. So just remember, starts from the sixth rib. This is the only thing you have to remember. Mid clavicular line or anteriorly, the visceral pleura extends till the sixth rib. Okay. Then you follow the visceral pleura and keep adding 2 plus 2. Visceral pleura in the front, 6th rib. Visceral pleura in the mid axillary line, 8th rib. At the back, 10th rib. Very simple. Parietal pleura, just add 2 spaces to each of these. Visceral pleura, parietal pleura anteriorly, 8th rib. Mid axillary line, 10th rib. At the back side, 12th rib. Okay. So first point, no odd numbers. Second point, two pleuras. You must understand this, the difference of the two pleuras. Visceral pleura is the one casing the lung, and the parietal pleura, which is inside the chest wall. So they are two different levels. So no odd numbers. Visceral pleura starts in the anterior mid clavicular line at the sixth rib. Just remember these 2 points. Then you keep adding +2 to everything. You continue with the visceral pleura, 6th rib, 8th rib, 10th rib, parietal pleura, 8th rib, 10th rib, 12th rib. Is this clear? Okay. So answer is A, 10th rib. Okay. They have asked you the parietal dura, mid axillary line. So parietal dura, mid axillary line, you come to 10th rib. Okay. Next. Sliding hiatus hernia. What structures travel to the same diaphragmatic aperture as the hernia? This is from what we had read in the previous class. Any more answers? Hello? Yes, guys, please say something. It may be wrong, no problem. Try. If you make a mistake, then we know where you are standing and why you got that wrong. We can discuss that. If you don't try, we will not know where you are not understanding. Right. Okay. So some people I see have answered B. If you remember, when we discussed the diaphragmatic apertures, there are three openings through which three groups of structures pass: the vena cava opening, the aortic opening, the esophageal opening. Nowhere did we discuss about the hemiazygous vein. Okay. Azygous vein, yes. Hemiazygous vein had not come anywhere. So B is straightforward cancelled. Okay. Now you understand this question. You know what is a sliding hiatus hernia. Okay. It is when the stomach and the G junction, it moves through the esophageal hiatus back into the thorax. Okay. That's a hiatus hernia. Through the esophageal hiatus, the stomach, the G junction is herniating. Hiatus hernia. So they have asked you what structures travel through the same aperture as the hernia. So it is they're talking about the esophageal aperture, esophageal hiatus. So what structures travel through that hiatus? It is the esophagus, obviously, with the vagus nerve. Right? Is this not clear to anyone? Please ask. Because I am seeing some people have answered B. Any confusion in this thing?
No, sir.
Okay. So read this. 25-year-old female, pain in right hand with tingling sensation and weakness. She is diagnosed with thoracic outlet syndrome. The affected neuromuscular bundle runs between the scalenus anterior and medius. So where do these muscles insert? Where are the others? Right. So it's a pretty straightforward question. It's the first review. So you have been asked to put a chest drain in a patient with penetrating trauma. Which anatomical landmark is least useful to you? Think of what we had discussed, the triangle of safety, the boundaries. Okay. So the triangle of safety, you remember this diagram. Now, some people might get confused with this term, anterior border. So the lateral border is also known as the anterior border, that's the dorsal. But in no circumstance does mid-clavicular line be of any use to you to put a chest drain. Okay. At what level does azygous vein enter the SBC? Previous question. Yes.
सर इसका आंसर सर ए
B.
आंसर क्या होगा सर?
Answer is B.
ओके सर, ओके
You
सर.
don't need the mid-clavicular line to put a chest drain. Clear?
Yes sir.
Okay. So at what level does the azygous vein enter the superior vena cava? Yeah. So for thorax, almost anything important they ask you is at the T4 level. Okay. Unless you're very unlucky, T4 is usually the answer for most structures for most events occurring in the thorax. Which of these descriptions most accurately describe the muscle relation to the phrenic nerve? Yes, more answers, please. Yes. Come on, guys, please answer. This is not for me to discuss, no, it's for you people to try and answer these questions. It's okay to be wrong here. We are all here to learn. So the answer is A, obviously. We had been discussing this even in upper limb. So I'll show you this diagram once again. This one, huh? So you see the scalene muscle. This is the anterior scalene. This is the middle scalene. The nerve anterior to anterior scalene is the phrenic nerve, along with the subclavian vein. Between the two scalenes lies the artery with the brachial plexus. All right. Yes or no?
Yes, sir.
Yeah. Last question. During angiography, a 56-year-old diabetic patient is noted to have a stenosis of the posterior interventricular artery. Which of the following most often gives rise to this vessel? So answer is the right coronary artery. Remember the posterior interventricular artery? This one decides the dominance of the heart, arises from the right side, so it gives the right dominant, left side left dominant. Huh? So for that, you remember that schematic diagram which we had seen. So this is the aorta. You have the right coronary. You have the left coronary. Right coronary giving the marginal, continuing as the posterior interventricular artery. Left one giving the left anterior descending artery, continuing as the circumflex and the left marginal artery. Okay. This diagram, please remember. Even if you forget the heart that I showed you with all the muscles and all, this one, please don't forget. These important named branches of the coronary arteries, they may be asked along with the origin, right or left. Okay. LADA, very important. This is from the left side. Okay. Clear, everyone?
Yes.
Right. So please keep practicing. Please practice more MCQs from your books. Go through the notes. We will come back with another topic the next class. Okay. Any doubts you have? Any slide you want to be shown again? Previous question. This one, yes. All right. Okay then. Bye guys. See you in the next class. Keep reading.